So this will be a pretty quick talk on the metabolic alkaloses. So this is part of the broader category of pH disturbances of the blood, particularly due to metabolism. And our marker here that's going to be disturbed in the alkalotic direction is going to be our serum bicarbonate. And so we'll have a blood pH greater than 7.45 and a bicarb that's greater than 28. So the basic principles of metabolic alkalosis is that it's a pH in your blood of greater than 7.45, and there are multiple causes. Very few symptoms are caused by the alkalosis itself. Usually the patient is going to present with symptoms that are due to the actual underlying cause of the metabolic alkalosis. So treating the underlying cause is going to be most important when you treat the metabolic alkalosis, because if you treat the underlying cause, the alkalosis will correct itself. You may see hypokalemia in these patients, so that may cause some weakness, and you may see ionized calcium decreases in these patients, which may manifest as Schwastek's sign or Trousseau's sign. I don't really want to talk about that, though, too much, because it's very rare for patients to actually present with these symptoms. They're usually going to present with other symptoms, which we'll talk about, and that are related to each of the individual syndromes that cause metabolic alkalosis. So history and labs are going to be most important, and the most important labs, of course, are going to be your blood pH and arterial blood gases. Those are going to help you diagnose the metabolic alkalosis. And then your complete metabolic profile to check for electrolyte abnormalities and urinary chloride. So look for these 4 labs, basic labs, to get to diagnose metabolic alkalosis. So these are the 4 categories of syndromes we're going to talk about. So the milk alkali syndrome is a hypovolemic alkalosis, and these are, simply put, your patients that have metabolic alkalosis, and when you delve into their history, they're taking antacids. They drink large quantities of milk. They're taking large calcium supplements. This is a very complex mechanism that the reason why these symptoms manifest. So I don't want to talk too much about the mechanism because it's just going to bog you down. What you should really know are the symptoms of milk alkali syndromes, which are hypovolemia and symptomatic hypercalcemia. So if you see hypovolemia and symptoms of hypercalcemia in a patient that is also diagnosed with alkalosis, then you should think of the milk alkali syndrome. What's going to help you out to diagnose this is that 100% of the time, these patients are going to have a history of taking high dosages of calcium or taking Tums, or they may have, the USMLE may throw at you that this patient has chronic gastric pain, they have acid reflux disease. So you can then assume that this patient is taking Tums or taking antacids. So that's a case in which the history is going to be really important. So like I said, milk alkali syndrome, you're going to see symptoms of hypovolemia, so low blood pressure, decreased capillary refill, and symptomatic hypercalcemia, which you may know by the mnemonic stones, bones, groans, and psychiatric overtones. So stones are nephrolithiasis, so kidney stones. Bones, you'll have bone pain. Groans, these patients sometimes will have abdominal pain and pain in other areas of the body, generalized pain. And then psychiatric overtones. Hypercalcemia can cause depression. Diagnosis here is going to be based on labs and history. As I mentioned, it's going to be most cases of metabolic alkalosis. You're going to have to delve into the history and make sure that you know if this patient is taking calcium supplements, are they taking calcium carbonate for ulcers or for gastric reflux disease. So the treatment here, first we want to treat the hypovolemia, because if you delve into the mechanism, what the reason is for this exacerbated alkalosis is actually the hypovolemia. So you definitely, when you diagnose milk alkali syndrome, you're going to want to hydrate them with a bolus of normal saline in all cases. So give them a bolus of normal saline, discontinue wherever the source is of calcium or alkali that they're getting that you've identified. And then once you've bolused them up with normal saline and they've attained euvolemia, then you want to start a loop diuretic. And that would be something like furosemide. And the reason that you start the loop diuretic is because loop diuretics, and I'm not talking about thiazide diuretics, just loop diuretics, so you don't use hydrochlorothiazide in these patients, just furosemide. What loop diuretics do is they increase the excretion of calcium. So this is basically an alkalosis that's caused by calcium, which is commonly seen in, well, it's always seen in milk and commonly seen in antacids. And having that high blood calcium due to a complex mechanism is causing hypovolemia. So we give them fluids to correct the hypovolemia, and then we give them loop diuretics to allow them to get rid of the excess calcium. And of course, we want to discontinue the calcium source. So I would just, unlike most disease processes, I would recommend that you just memorize the symptoms and the treatment and don't try to get a deep understanding of the mechanism, because it is a very complex mechanism and it's not completely understood. So rehydrate the patient, stop the calcium source, and then start a loop diuretic. And these patients should be advised to not be overdosing themselves on calcium and on antacids. So these are patients usually that have gastric reflux or ulcers, and they should be started on PPIs or on H2 antagonists to ameliorate their gastric symptoms rather than just be popping Tums all the time. So remember the symptoms: the hypovolemia, the hypercalcemia, and then the treatment, which is fluids and loop diuretic. GI loss is another cause of alkalosis. This too is going to be a hypovolemic alkalosis, and this is simply an alkalosis because they're losing endogenous acid from their stomach. They're losing hydrochloric acid. So if you're losing acid from your body, the natural thing that's going to happen is that your blood is going to become more alkaline because you're losing acid from your body. What's also going to happen is, due to the fact that the blood is more alkaline, you're going to have a reduced hydrogen excretion, so you're going to have a reduced potassium reuptake. And so because you have a reduced potassium reuptake, you're going to have hypokalemia. So the most significant problems in these patients that have alkalosis due to GI loss is actually their hypokalemia and their volume depletion. And the reason that these patients are going to present is not due to alkalosis, it's not due to hypokalemia, and it's probably not even due to their volume depletion. These patients come into the ER because they've been vomiting. They've been having frequent vomiting, or maybe they're even bulimic patients. So these are going to be patients with a history of vomiting. You do your labs, you find out they have a hypovolemic alkalosis, and they also happen to have hypokalemia. When you know that the patient's been vomiting frequently, you should definitely take a look at the rest of your electrolytes, because vomiting causes disturbances in electrolytes, not just to potassium, but to chlorine and sodium. So this is going to be your hyponatremic, hypokalemic, hypochloremic metabolic alkalosis. You're going to have a low sodium, a low potassium, and a low chlorine. So when you see a patient and your labs say, even if it doesn't tell you they have a history of vomiting, if your labs show a low chlorine, a low sodium, and a low potassium, your diagnosis, until proven otherwise, is going to be GI loss. These patients are also going to have a low urinary chloride, and that sets GI loss apart because all the other metabolic alkaloses are going to have a normal urinary chloride. So why do these patients have a low urinary chloride? The reason is because they're losing hydrochloric acid from their body in the stomach acid. So if your serum chloride is low, your urine chloride is going to be low. So another way you can diagnose this is that the patient, if you get their urine electrolytes, their urinary chloride is going to be low. But generally the way this is diagnosed is either the patient has a history of vomiting and they have hypovolemic alkalosis, or they have labs which show hypochloremia, hyponatremia, and hypokalemia. The treatment here, like in any vomiting, you're going to have to replenish their volume. So give them a bolus of normal saline until you feel that they're euvolemic. Just make sure you don't give them too much. And then you're going to want to treat the hypokalemia. You can, if the patient is having ongoing vomiting, then you're going to want to give them potassium chloride through their IV. But if the vomiting has stopped, then you can go ahead and give them oral potassium supplement. And of course, if they're having ongoing vomiting, then you're also going to want to use an antiemetic. So ondansetron or metoclopramide are both fine choices. And then treat the underlying cause if there is one. So patients who use diuretics are at risk to develop alkalosis. So loop or thiazide diuretics cause potassium wasting. Remember, they inhibit sodium reabsorption, so by nature they are going to cause potassium wasting. And so if you have more potassium in the filtrate, that's going to increase the activity of the hydrogen-potassium pump, so more hydrogen is going to be excreted. So here's sort of a visual of this. Loop diuretics inhibit the NKCC channel, which is in your ascending limb of the loop of Henle. And what's going to happen there then is you're going to have more sodium and more potassium in your filtrate. Thiazide diuretics are going to inhibit the NaCl channel in your distal convoluted tubule. And so what's going to happen there is, even though you're not inhibiting the reuptake of potassium, because you have more sodium in your filtrate, you're going to exchange sodium for potassium. So you're going to have more potassium in your filtrate. The thing that these both have in common is that both loop diuretics and thiazide diuretics, either directly or indirectly, are going to increase the potassium in your filtrate. When you increase the potassium in your filtrate, you're going to trigger the action of this channel, this hydrogen-potassium pump, which exists at the distal part of the collecting duct. And if you have more potassium in your filtrate, you're going to pull potassium in, and it's going to be at the expense of acid. So you're going to have more acid in your urine, and because you have more acid in your urine, you're losing acid from your blood, and therefore you have an alkalosis. So both loop diuretics and thiazide diuretics will cause a metabolic alkalosis. And this is, when you diagnose this, all you really need to see in these patients to make a presumptive diagnosis is a history of diuretic use. So symptoms are, this is just an adverse effect of loop diuretics and thiazide diuretics. Patients will often present with symptoms also of hypovolemia or hypokalemia. So they may have weakness or they may have volume depletion. But in most cases, this is going to be a coincidental finding. So don't expect patients in the ER to present with alkalosis due to diuretic use. This is usually going to be something that comes up on your labs in a patient that's already admitted to the hospital. So diagnosis is just simply a low serum potassium or hypovolemia and a history of concurrent diuretic use, either loop diuretics or thiazide diuretics. When I say diuretic use, I don't mean the potassium-sparing diuretics. So that's not associated with hypovolemic alkalosis. The treatment here is pretty simple. You're going to replace the volume as needed, and then replace your potassium as needed if they do have hypokalemia, and orally is going to be fine. And then consider reducing their diuretic dosage or switching them to a potassium-sparing diuretic. And then this just shows the mechanism. It's very good to know where the loop diuretics and where the thiazide diuretics work. And there's two syndromes called Bartter syndrome and Gittleman syndrome, which I like to call the pseudo-diuretic syndromes. And so these are going to be patients that present identically to loop diuretics and thiazide diuretics. They're going to have the hypovolemia and the hypokalemia, but you're going to find out on history that they're not on diuretics. So these are congenital conditions, and so you'll have a hypovolemic hypokalemia, and you'll also have a metabolic alkalosis. And it's just due to the exact same mechanism as taking diuretics. It's just that these channels are a little underactive. So either your NKCC channel or your NaCl channel in your distal convoluted tubule will be underactive, causing a higher potassium in the filtrate, which ultimately results in increased hydrogen ion excretion, so an alkalosis. So this alkalosis is due to different cause, and the actual way you're going to set this apart is that you're going to have patients here who are hypervolemic. So remember, the other three causes, those were all patients who were hypovolemic. These are patients who are hypervolemic, and the reason is all of these patients in general have high aldosterone or high cortisol states. And so Cushing's disease, Conn syndrome, Little syndrome, or small cell lung cancer all cause increased activity of cortisol or aldosterone, all of which will increase your likelihood of developing alkalosis. So what all of these have in common is, remember, both cortisol and aldosterone work at the same site. So cortisol and aldosterone cause increased reuptake of sodium, and if you have an increased reuptake of sodium, you're going to have lower potassium in your serum. So anytime you have high aldosterone, you're going to have increased serum sodium and decreased serum potassium. And remember, back to here, if you have a decreased serum potassium, what's going to happen? You're going to reuptake potassium in your distal collecting duct. So if you increase your reuptake of potassium, which always happens if you have in patients with high aldosterone states, you're going to develop a alkalosis because you're secreting all that hydrogen. So these patients, again, are going to present with symptoms that are due to their underlying cause. So look for hypervolemia, look for possibly symptoms due to their hypercortisol state. So if you have Cushing's disease, you may see striae, buffalo hump, facial hair, high blood pressure, weight gain. Conn syndrome, because it's due to aldosterone, not cortisol, these patients aren't going to have the striae, buffalo hump, facial hair, weight gain. They're pretty much just going to have the high blood pressure. They may have weight gain due to edema, but they're definitely not going to have the striae, buffalo hump, or facial hair. That's due to the cortisol. So look for these symptoms in patients with high aldosterone states. The way you're going to make your diagnosis here is going to be sort of tailored towards what you're suspecting based on the symptoms, because not all of these present the same. Small cell lung cancer may present as a hypervolemic alkalosis and hypokalemia in a patient who has difficulty breathing or a chronic cough and has a 20-year history of smoking. Little syndrome will often present in a child. Cushing's disease and Conn syndrome Cushing's disease will present with the striae, buffalo hump, facial hair, possibly decreased or increased time between periods or amenorrhea. And Conn syndrome will generally just present with high blood pressure and weight gain. So based on what you think the cause is, what you're going to want to do, definitely you're going to want to always get an aldosterone-renin ratio, because that's going to help you differentiate out Conn's. And Conn's is going to have a high aldosterone-renin ratio. Why is that? Conn syndrome is a tumor it's a aldosterone secreting tumor in the adrenals. So because you have this tumor in your adrenals secreting aldosterone, you're going to have a high aldosterone to renin ratio. Remember, renin is the first part of your renin-angiotensin aldosterone system. So renin is the trigger for aldosterone. So you would expect that in a patient with high aldosterone, they also have high renin, because the renin is causing that increased aldosterone. If the patient has high aldosterone but low renin, then you think about ectopic secretion of aldosterone, or Conn syndrome, because you don't have the trigger for aldosterone, you just have the aldosterone. So if your aldosterone-renin ratio is greater than 30 to 1, then definitely gear your diagnosis towards cons. If it's not greater than 30 to 1, then you should look more towards Cushing's or possibly Little syndrome or small cell lung cancer. Cushing's, you're going to suspect based on the striae, buffalo hump, and facial hair. That's very, very, very stereotypic of Cushing's, and also a very rapid weight gain. For Cushing's, to diagnosis, you do a dexamethasone suppression test, and getting a CT can also be useful because it can sometimes help you find a tumor if there is one. But definitely get your dexamethasone suppression test for Cushing's. That will help you make the definitive diagnosis. And then, of course, in a patient where you suspect lung cancer, because small cell lung cancer causes ACTH secretion, you're going to want to get a CT on those patients. Little's syndrome is rare. It's usually going to present in children, and the diagnosis is going to be one of exclusion. Obviously, you're not going to suspect small cell lung cancer in a patient, but Conn syndrome or Cushing's disease you can suspect in a pediatric patient. So Little's is really your diagnosis of exclusion. The treatment here is going to be surgical therapy. In Cushing's or Conn's, we're going to want to get either the ACTH or the cortisol secreting tumor out. For Little syndrome, we're going to use potassium-sparing diuretics, which is either amiloride or triamterene. And for small cell lung cancer, we're going to treat that as we would any cancer. We're going to have to stage it, and we're going to have to get a biopsy. We'll talk more about that in the pulmonary section. And what Little syndrome is, I didn't touch on the mechanism. If you're familiar with the ENaC channel, what the ENaC channel is in the collecting duct, and it's really just a glorified sodium-potassium channel. And so ENaC increases the reabsorption of sodium and causes a increased secretion of potassium. And so our potassium-sparing diuretics inhibit ENaC. What we have in Little syndrome is an overactivity of ENaC. So you're going to have more sodium reabsorption and more potassium secretion. And remember, I've said this twice before, but it should be drilled home that if you have more potassium in the filtrate, you're going to increase your hydrogen ion secretion because that's your body's way of trying to correct the hypokalemia. So this is the mechanism behind Little syndrome, and it's a congenital syndrome, and because we have a hyperactive ENaC, it makes sense to use potassium-sparing diuretics because potassium-sparing diuretics inhibit ENaC. So this is a nice way to make sense of all this. These are a lot of very unrelated conditions, and so this is sort of your diagnosis tree. So when you have a patient and you see metabolic alkalosis, the first thing you're going to want to do is you're going to want to ask yourself, is the patient using an antacid or calcium supplements? If yes, your diagnosis of presumption should be metabolic alkali syndrome, and you should check your serum calcium. And if that's high, then you can go ahead and make the diagnosis of metabolic alkali syndrome, and you'll just bolus them and discontinue the calcium source and give them a loop diuretic. If no, then you should check the urinary chloride. Remember, if you have a low urinary chloride, or if you have a history of vomiting, then you probably are going to have GI loss. Sodium, potassium, and chlorine are going to be low in these patients. That may be another way that the USMLE tips it off for you. If the patient, if they have a normal urinary chloride, or you're not thinking GI loss, then you ask yourself if the patient is hypertensive. If the patient is hypertensive, then you should check your aldosterone-renin ratio. An aldosterone-renin ratio of greater than 30 to 1, you should consider Conn syndrome. If it's less than 30 to 1, then you should consider either Cushing's, Little's, or small cell lung cancer based on the patient. If you have a dramatically overweight patient who has the buffalo hump and the striae and the facial hair and the amenorrhea and all those stereotypical things in Cushing's disease, suspect that, get a dexamethasone suppression test. If it's a long-term smoker, get a CT. If it's a child, think possibly Little syndrome, but definitely rule out Cushing's. the patient is hypotensive or they're normotensive and they have a history of diuretic use, think of it possibly being the adverse effects of diuretics. In that case, we're just going to discontinue the diuretics. If they don't take diuretics, then consider Barter's or Gittleman syndrome. And hopefully that helps you make sense of the metabolic alkaloses. Most important thing to remember in metabolic alkaloses is just look for the other symptoms, not just symptoms of alkalosis. Look for symptoms of the underlying cause, both symptoms and history. That may tip you off to the underlying cause. And that is it.